We are now going to move on to our live panel discussion about the future of care for pelvic radiation disease in the UK, which I know is going to be very interesting. So it is my pleasure to introduce the panel. The chair, Professor Diana Greenfield, who you heard from earlier. Hello, Diana.
Hi.
And the rest of the panel, Dr. Lisa Durant, who is Consultant Therapeutic Radiographer at the Radiation Late Effects Service in Musgrove Park Hospital, Taunton. Hello, Lisa.
Hello.
Margaret Snedden, Honorary Senior Research Fellow, University of Glasgow, and Chair of the British Lymphology Society, who you also heard from earlier. Hello, Margaret.
Hi, everyone.
And Dr. Louise Hanna, Consultant Clinical Oncologist at the Velindre Cancer Centre in Cardiff. Hello, Louise.
Hello. Hello. Hi.
Dr. Shamir Mehta, Consultant Gastroenterologist at the Royal London Hospital and Honorary Associate Professor at the University College London. Hello, Shamir.
Hi, everyone.
Right. Lovely to see you all. And over to you guys.
Thank you. Thanks, Boomy. And it's lovely to be here. Welcome from sunny Sheffield and to all of you all over. We're going to kick off with lots of questions, and I'm hoping this is going to be a really stimulating discussion. My first question, actually, is actually one that you posed, Lisa, and I'd like to give this back to you and then perhaps to the other panel afterwards. And it was one that you posted about, do you think patients with PRD would be happy to use the pathway document to challenge their GP or other healthcare professionals if they're not getting the referrals they need?
Thank you. Yeah, I'm just really keen to know, because there's patient voices on the chat box about whether they feel enabled with this document now. It's such an important document for myself as a healthcare professional, but I'm really keen to understand if patients will be able to use this to take it to their GP to help us drive developments and help them to get the care they need.
And do you think they could?
I'd like to think so. I'd like to. I don't know how easy it is with a 10-minute GP appointment to take a document with you and,
yes,
challenge them, or whether patients feel they need tools to be able to challenge their GP.
Yeah. Well, maybe we could put that to some of the other panel members. I wonder, Margaret, do you think they should be using this document to challenge their healthcare professionals?
I think there should, and I'm just wondering about a strategy that we use in lymphedema, in that patients have a card that has a QR code that goes directly to our cellulitis document, for example, that they can take to hospital GP and say there is guidance on here, because I think GPs now are more likely to look something up online if it's easy to do rather than read something that they're handed.
Okay, well, that's something to note, a QR code. And I wonder whether any, Shamir or maybe we'll come to you and ask the same question, really. Do you think the patients will feel empowered to use this document to help seek the advice that they need?
I mean, I hope so. I mean, I think there's two things I would say. One is that, I mean, I'm not a patient, so it's difficult to say on behalf of patients. But I would say that I think this is a really important document, and I think it's something that we've been thinking about for a number of years, almost as a call to arms to bring everything that we know that's important about pelvic radiation disease together. And hopefully it's a document that patients can use to enable these conversations with their healthcare professionals, be that in primary care or secondary care. But I think the second thing that I would say as a healthcare professional is that we should also be happy to have those conversations with patients. And I think we are having those conversations with patients more and more, where patients are bringing us medical options and information that perhaps weren't known to us prior to the consultation. So I think hopefully this document will be sort of used as a push and a pull, really, pushing from patients, but also have us as healthcare professionals happy to receive that as well.
Yes, a push and a pull. That's a good one. So, Louise, did you have anything to add?
Yes, thank you. I think with sort of increasing pressure on GP services, you know, particularly post-pandemic, speaking to GP colleagues, you know, there are difficulties with telephone consultations, and sometimes patients might be presenting with multiple problems which are difficult to assess in a 10-minute consultation that the GPs have. And so the more that the more understanding that patients can have in order to help almost to direct their GP to what the key problems are, I think that the better. And I would certainly hope that patients feel able to use this. As a healthcare professional myself, if there is any guidance or best practice guidance or any pathways, I'd always be very, very willing to know about those and to use those, because the more that we can sort of adhere to national standards, the better, and that helps us to increase our confidence in that we're dealing with things in the right way. So I would very much hope that patients do feel able to use this document to be able to sort of verify their symptoms and to help them to articulate their symptoms, and even to use it to direct what needs to be done.
Yes, okay, thank you. So this is, in terms of future of care, this really could help individual patients getting there more quickly rather than being bounced around, which is currently what we hear is very often the case. Now, just sticking with the GPs, there was, I think, a question from a GP which said, this is a great document. Is there a specific method for healthcare professionals, especially GPs, to assess the severity of a specific symptom? I think GPs, we're all familiar measuring pain using visual analog scores, but not so much for other symptoms related to PRD. Now, of course, we're going to be all day if we start using this for every single symptom, but was there any particular thing related to your own specialism that you would like to add to that? And perhaps I will start with Margaret.
I think it's really difficult because it's probably more appropriate that they refer the patient if they suspect lymphedema and swelling that's not going down overnight or very easily. But and to focus more on things like the cellulitis, risk of cellulitis, recognising that. And yes, there are specific points to look for in that as outlined in the presentation. But other than that, I think there's things you can do to reduce the risk, and it would be great if GPs knew that.
Okay, so perhaps the QR code idea as well. Okay, perhaps we'll come to Shamir for a specialist answer there.
I think this is a really interesting aspect of gut toxicity, because the severity grading is something that's actually missing from this when we talk about gut toxicity. There are only really, in my mind, two areas in which we can grade severity. And one is for bile salts diarrhea. You know, we can do SECAT scans and we can grade mild, moderate, and severe objectively. How useful that is clinically, I think, is slightly debatable. And the other area would be radiation proctopathy in terms of severity of bleeding, anemia, iron requirements. Beyond that, when we're thinking about things like transit problems or evacuatory problems or bacterial overgrowth, we don't have good tests that tell us about severity, and importantly, relating that to patient symptoms and response to treatment. And I think that's one area that perhaps we need to work on. I think if you're a GP and you're seeing patients with gut symptoms, once you've excluded a primary cancer, because I think that's the first thing that we will always recommend, and we're then talking about pelvic radiation disease and gut toxicity, I think it's very much dependent upon the patient's quality of life. And I think your management would be directed upon symptom burden and their quality of life.
Okay, that's really helpful. So we've got identified some research questions there and some practical advice for GPs on assessment. Now, coming to Louise, to the clinical oncology setting, we used to, the audience will be mixed. So we talk about toxicity grading, don't we, in oncology? I wonder whether you might just give us a brief resume of that and how that might apply to the future of care in terms of late effects assessment. Sorry, you're muted, I think, Louise.
Apologies. So there are particular grading systems that can be used. I think building on what Shamir was saying, obviously if somebody presents with symptoms following pelvic radiotherapy, then there are a few things that need to be gone through first of all, which is to check for a recurrence or a new cancer. And once those have been excluded, then obviously then you can start to go down the kind of late effects route. Now, in terms of severity, obviously there are red flags that GPs use, red flag symptoms that might alert the need for urgent investigation. But I think one key thing is for things that aren't necessarily urgent red flag symptoms is the impact on the patient's quality of life. And so there are a variety of different ways that you can score late effects. One of them is sort of objective and the other is subjective. And a key thing for us is the impact on somebody's quality of life. We heard in one of the earlier talks about somebody who was opening their bowels 9 times a day, I think it was. Some people have late effects of pelvic radiotherapy and they manage these themselves, either by modifications to their diet or simple medication, and some of them don't feel that they want to be investigated because with all the treatment that they've had, they feel they've been through enough, and if they can self-manage or deal with them, or sometimes just put up with them, they don't feel that they need further investigation or treatment. But there are a lot of people who are really debilitated, and so it's really the impact on the patient in terms of the disruption to their life and their quality of life.
Okay, thank you, Louise. That's really clear. And I'm just wondering, Lisa, now coming to you, because you lead and run a late effects service. So you're receiving patients for after the referral, and how helpful is it for you to have had a good assessment? So sort of the other way around on the receiving end.
It's really important to have a good assessment. It's important for us to understand what's happening to the patient, but it's also important for us to understand further down the line if our interventions are helping, so that we can build pathways and know how we can help patients. So quite often we do assessments before they have any treatment with us, and then further down the line. I think one of the problems we've got though is that we don't have a specific set of symptom measurement tools for late effects. Everyone's using something slightly different, which then makes it quite difficult to compare or to get big data. And I think the other thing to bear in mind is how we would grade symptoms is sometimes quite different to how a patient would do it, or again, as everyone has said, the impact on their life. There are some simple tools that perhaps we should look at developing further. So, for example, there's the Alert B tool, which is quite a lot of information that's been distilled down just to try and find out what the most important things are for patients with some bowel symptoms. And perhaps we need that for all the other sites as well, like bone, bladder, sexual function. I think the great thing with this document, though, is actually we can start to look at that now. So now, for the first time, we've actually got all the different components of all the different systems of pelvic radiation disease. We can start thinking about how can we best get the information about patients' symptoms and their severity.
Okay, Lisa, that's a really useful point. So actually what we need then is to have a portfolio of assessment tools that we're recommending, and that's an action to do then. And Margaret, I think you wanted to come in and make a point at this stage too. I think you're on mute, sorry.
Thank you very much. I just wanted to go back and say that obviously after checking that there's no recurrence, there isn't really a place for a wait and see approach with lymphedema, because the earlier it's treated, the less impact it will have on somebody's quality of life. And even if they have other problems, such as cardiac problems causing that edema, which need to be treated appropriately, if the edema is persisting, then there's something wrong with the lymphatics that needs to be addressed sooner rather than later.
Okay, thank you. Good point. So now moving on to some, we've got some time left. We're talking for another 20 minutes or so, and I do have some further questions just to move on. Now, starting at the very beginning, one of the recommendations in the best practice for moving for future care is consent. And consent at the outset of radiotherapy. And so my question to you, Louise, could consent for radiotherapy be better?
I think there's always room for improvement in consent. And I think some of the issues with consent is that when patients have been newly diagnosed with a cancer, their whole life has been turned upside down. And they are very much focusing on the treatment that they need. There's a huge amount of information to give to patients, and often patients want to focus on the treatment. And although obviously we do discuss with them about the acute and late side effects, it can be very difficult for patients to process all that information. And I think the other thing is that different patients need different amounts of information. You know, there are some patients who want to know absolutely everything. And there are, booklets, the Macmillan booklet on managing late effects of pelvic radiotherapy, which is a very large booklet. Some patients want to read the whole of that, and other patients really don't want to know very much at all. They just want to get on with their treatment. So I think the important thing really is to give information in a way that patients want and need, and also to be aware that the consent is a process. It's not just the matter of signing the consent form. It's a matter of multiple discussions and giving the patients the ability to ask further questions should they need it. The Royal College of Radiologists has recently developed standardized national consent forms, which I think are a very big step forward, and they can be very helpful in highlighting the areas. And then the other thing is that obviously after the treatment, ongoing education and support for the patients is important, because patients might not have wanted all the information before their treatment, but they might want further information after their treatment. So it really is a matter of trying to establish relationships with patients so that they feel comfortable, able to ask when they're ready, able to ask questions, and that they and signposting them to information and support. So the answer is yes. I'm sure things can be improved.
Thank you, Louise. And I think the key thing there is that consent is a process, that patients have individual needs. So it's an ongoing relationship and exchange of information. So thank you for that. I just wondered, Lisa, as a therapeutic radiographer, whether you had anything to add to that, particularly the process, the consent being a process, and are there any teachable moments or opportunities further down the line?
I totally agree that the new consent forms in the RCR are much better. And if we ask patients now, did you understand that you could develop late effects? They do now, whereas I think previously they didn't. I think, as you say, it's a process, so we need to carry on with reinforcing that information with patients. So we had an end of treatment review when they finish their treatment to make sure they understand that things could change in the future. I think the important thing is to remember, though, that it's all very well telling patients that these things can happen further down the line, but what we need to be doing is telling them what they can do about it. So if they develop problems further down the line, they don't just need information, they need a way to access services again. Yeah. And that's why this has kind of been so important to help highlight that.
Thank you. Well, that's a wonderful segue actually into the next question. Thank you, Lisa. So the next question, Shamir, if I may, what are your top tips for any patients listening who are experiencing bowel issues and not receiving specialist care?
I think it's really important. I think the reason this is important is the point that Lisa just made, in that, yes, consent's important, but actually what we need to be doing is being adaptable and flexible to that patient journey. So if they develop symptoms, in the ideal world, they have access to advice and care and seeing a dietitian if needed be, for example, or somebody else. In the absence of that, yes, we do need to give patients some practical advice. And I think actually the best practice document covers a lot of this, particularly, for example, the basic practice section, talking about things like diet, talking a bit about things like medicines and certain over-the-counter medications which might be compounding their symptoms. I would really like, if possible, to have access to dietetic services during and that immediate period after radiotherapy. I think that's really important. And I think these are evidence-based strategies that we know that certain fiber supplements, certain dietary strategies can help. We've had a randomized control trial published quite recently, which shows that, you know, a gastrointestinal care bundle in that early period can impact outcomes at 1 year. And we know that patients that have acute toxicity are unfortunately more likely to develop chronic toxicity as well. So there's lots of really good practical tips in this best practice document. But what I would really like that to be not the end of the journey. I want that to be the beginning. I want that to be a springboard for us to say, we also need to support patients from a service perspective as well.
Yes, I think that's a really good point. So a message from there is that particularly on my own research and research I've read is very much patients really value that dietetic support early on, and it's very limited in its scarce supply. So perhaps this document could be used, as you say, as a springboard to try and help commission services and improve services and access to that specialist care, not just medical care and supportive care, but the specific therapy dietetic input. Thank you. May I then the same question really to Margaret. Do you have any top tips for patients who have symptoms of lymphedema symptoms who've read the document and are uncertain how to seek help?
Well, I think people can often dismiss what seems to be a little bit of swelling, and hopefully the document is a good pointer that they shouldn't ignore these things and they should see about it and encourage their healthcare professional to take it seriously. And I think the patients don't always remember all the complications you suggest that they may experience later on. So I think it's good for that, and it's good for professionals to think about them all and perhaps almost be screening for problems with these every time they see a patient. But in terms of getting help, if they think they've got lymphedema, it's usually through the GP. Sometimes people can go directly to lymphedema service. But so once they've excluded other cancer, then I think it's probably worth contacting an organisation like the BLS or the Lymphedema Support Network if they're having difficulty in getting access to a proper lymphedema assessment.
Thank you. And that also applies to the other symptoms, of course, in the document with the same principles. So thank you to Shamir and Margaret on that. Now, of course, we're trying to use this for future care, the best practice document to drive support and commissioning services and getting access to existing services and improving those pathways. But that all depends on a very informed and educated workforce. So I would quite like now to switch some of the discussion to that, if I may. So a question for you, Louise. Oncology services are facing unprecedented pressures. How can the PRDA pathway be embedded into routine practice given these challenges?
So I think one of the things is that obviously the late effects of pelvic radiotherapy involve multiple professional groups. And I sometimes reflect on the fact that, you know, I'm a clinical oncologist, I deliver pelvic radiotherapy, but I'm not necessarily the expert who can deal with all the issues. And so if you think about all the different professional groups that might be involved, it's very vast. We have a late effects of pelvic radiotherapy service that has been set up with our fantastic team here. And one thing that they can do is to signpost. What we do is we have a screening questionnaire that we send to patients, and that will help to direct which professional they need to see, or more than one. That can be very helpful. It's not a comprehensive thing with every single symptom. It's mainly related to the professionals that are in the late effects service, but obviously late effects is much wider than that. So a lot of what can be done within existing services. You don't, you know, if you've got bowel problems, you don't necessarily need to go through a late effects clinic in order to be referred to a gastroenterologist. We have had in the past, we've had sort of day sort of teaching training sessions where we've invited multi-professional groups, and I think education is multi-professional education, multidisciplinary education is a great way of enthusiasm and of getting people enthusiastic about how to deal with it and raising awareness as well. So I think education, setting up late effects service when you can, but also I think that the key people in the oncology team, the specialist nurses, are fantastic as well at identifying issues and then referring on to other professional groups, whether or not they're formally part of the late effects service.
Thank you.
If that quite answers the question.
Yeah, well, you've actually raised a number of issues, actually, which and some of them actually lead on to some of the questions we've received. So thank you, Louise. I think probably I will pick up one of the points that you made about that the multi-professional involvement is very important, and having multi-professional education. And you don't necessarily have to have the specialist, particularly with the gastroenterology. Now, however, some research shows that not all gastroenterologists know about PRDA. So I just wonder, Shamir, whether we could come to you for this question, which is what needs to be done to embed PRD assessment for diagnosis and management, or routinely embedding that into gastroenterology specialist training.
I think that's exactly right. I mean, we do need to weave this into national training curricula formally. I think, you know, I think that it's really, we need to be aware of the competing interests that gastroenterology consultants have in terms of their jobs. And I think that there's a perception that patients with pelvic radiation disease make up a small proportion of their work. That might be the case, but that's probably because they're not aware of the numbers of patients that require their help. And I think that we need to part of that with actually having the trainees coming through already having an awareness of pelvic radiation disease, so that when they are consultants on day one, we're not having to almost have that discussion with competing interests. They're already aware of pelvic radiation disease as a clinical entity, as it relates to them in gastroenterology. They're aware of the need for these patients and the symptom burden, but also understanding that there is a need to develop services in whichever hospital that they're in. And of course, you know, the Royal Marsden have done an amazing job of doing lots of work in this area, but the majority of patients are not looked after at a dedicated radiation disease service like the Royal Marsden. They're looked after in general gastroenterology clinics or you know, inflammatory bowel disease clinics. And so we need to have trainees aware of how to develop services when they're becoming consultants. And so things like training days and adding on to curricula is definitely the right move forward.
Thank you, Shamir. So we have 5 minutes left, and I would like to bring in this training issue, workforce development for the other specialists too. So Shamir, we've talked about the gastroenterologist, both in terms of the curriculum and then postgraduate and ongoing training and education once become consultants. So Louise, just before we move to the therapy, to involve the radiotherapy and the physio and others, I just wonder if we could come back to the clinical oncology training. For future services really depend on a first workforce who are educated, as we mentioned. And so what needs to be done to ensure clinical oncology trainees are adequately prepared?
Yeah, so I think has been mentioned as in a previous talk today, awareness of late effects is part of the clinical oncology curriculum now. And so trainees, doctors in training will be taught about this and will be assessed on this. And I think the other thing that we can do as well is that when as oncologists we refer patients to other specialist services, we can actually signpost the resources that are available, such as the Royal Marsden algorithm or now the best practice pathway. So we can highlight those. Yeah.
Thank you, Louise. So, moving on to you, Margaret, in terms of not just the lymphedema aspect, but from a physio perspective, I wonder whether you might answer that question about getting PRD awareness within physio training.
Well, I'm actually a nurse, but
apologies, Margaret. I thought you were a physio by background. Well, we've got a question about nursing too.
I think we have struggled with this because there tends to be education in lymphedema when you have someone locally, who is a specialist, who will feed into a particular university. In other areas, it's not so well addressed. And I also think my perception is it's probably better addressed in physio training than in nursing training generally. But I think that's getting better. But there is a document about what patients should be able to expect of any healthcare professional at point of registration in relation to lymphedema. And we're a long way from achieving that basic standard because there's always the argument that there's too much in the curriculum. So it has remained a postgraduate.
And that's probably where it should remain. Okay, we are coming to a close of our discussion. I can't believe it. And we haven't got through all the questions. I'll just come to Lisa just for a brief response to that one, please, about getting into education and training.
I think it's happening, and I think actually it's accelerating. So within therapeutic radiographers, we started a special interest group for late effects, and suddenly more than 100 people had signed up all around the country. So there is a huge interest for it. It's just trying to formalise it, but I think it's seeping in. So if it's become, coming into oncology training, but we should be teaching it at an undergraduate level so that people are aware of it. But I think part of the power comes from the patient voice. So the fact that patients are asking about this now is actually a really powerful part of driving.
So the PRDA has a role in shepherding the patient voice and collectively getting that to drive this agenda forward to help with the training. And they're both the specialist training for doctors and the postgraduate training for other healthcare professionals. So we did want to make a point, of course, there was a question about how important clinical nurse specialists are as gatekeepers to assessment. We haven't got time to do that, but I do think we need to acknowledge that the clinical nurse specialists in every cancer team, and also let's not forget primary care, there are practice nurses and district nurses who see a lot of our cancer patients who can be gatekeepers to assessment for onward referral for PRD symptoms. So I just wanted to just finish, if I may, just that there were some specific questions about very specialist things, for example, bile acid malabsorption, Shamir, and what we might do, if it's okay, is to direct those to you offline. And there were some, we also just wanted to let the audience know that if they do have any specific questions, they can email the PRDA and we will forward those on, if we may, to specialists just to be able to respond to very specific questions. We're right on the nose now. We didn't answer all those questions, so I hope we answered as many as we could. I want to thank the panel for their really excellent contribution to be able to drive forward the future of care for patients with pelvic radiation disease. And thank you very much. And we'll hand over back now to finish off. So thank you very much, everybody.